Thanks so much for joining us today for the advancements applications of antibody drug conjugates in HER2-negative breast cancer. Today's presentation is brought to you by Creative Educational Concepts and is supported by an independent educational grant from Gilead Sciences. Again, this program is brought to us by Creative Educational Concepts, and we thank them for their support as well. My name is Sarah Tolaney. I'm a breast medical oncologist and chief of the Division of Breast Oncology at Dana-Farber Cancer Institute in Boston, and I'm excited to do this presentation for you all today. Listed here are my disclosures. So we're going to start off with some of our learning objectives just to give you a high-level overview of what we're going to cover. So the first learning objective is to evaluate unmet needs in the management of metastatic HER2-negative breast cancer, including expanding treatment options for those who have progressive disease and the implementation of policies to promote equitable care. The second objective is going to cover selecting patients with HER2-negative metastatic breast cancer who have progressed despite prior therapy to receive antibody drug conjugate-based regimens based on guidelines, expert consensus, and the latest clinical trial findings. The third objective is to integrate strategies to monitor for and manage adverse events in patients who are receiving antibody drug conjugates. So to start off with, we're going to focus a little bit on health disparities in the management of metastatic breast cancer. We know that 5-year breast cancer-specific survival rates are significantly lower in Black patients compared to white patients. We also see that the median age at death due to breast cancer is also younger in Black patients compared to white patients, as you can see as shown here. We also know that triple-negative breast cancer is more prevalent in Black women than in other races and ethnicities, and worldwide, the highest rates found in Black women from the United States and in West Africa. And this contributes to excess breast cancer-related mortality amongst Black patients, but certainly is not the only explanation. I think this is not just solely an issue about race and ethnicity. We also know that the incidence of triple-negative breast cancer is twofold higher in Black women compared to white women, and it does disproportionately impact younger premenopausal patients. And we also know that having a germline BRCA mutation is also associated with having triple-negative breast cancer. So as we were saying, I think this is not just a factor of race and ethnicity. We certainly also believe that socioeconomic disparities play a role here, where we know that patients who may come from lower socioeconomic backgrounds tend to have lower rates of screening, higher likelihood of diagnosis at a later stage, often have inadequate and or inequitable care, which can be associated with higher mortality rates. We unfortunately also see that patients who come from lower socioeconomic backgrounds tend to have less insurance coverage, either no insurance or be underinsured. And it's also really tough to take time off of work. Many of these patients, if they miss a day of work, aren't getting paid. And so to come in for medical appointments becomes really very burdensome to patients. We also know that patients may live in areas where they don't have great access to medical care. They may live a distance away from a large academic center, for example, may not have adequate transportation, may not have the resources for childcare to be able to get to a medical appointment. So all of these factors certainly play a role. And so outside of race, ethnicity, and socioeconomic factors, I think there can be lifestyle factors that also influence this higher rate of breast cancer, including higher rates of tobacco, alcohol use, being more likely to have obesity, more physical inactivity, and certainly nutritional factors may also play a role. So again, this is multifactorial and certainly not just one factor. Biology certainly can influence this, where people from different races and ethnicities may have biologically different cancers. So again, this is complex. When we look at the distribution geographically, you can see that you can look across the country and see that there are areas across the country where there is a disproportionate amount of patients living within the poverty range. And you can see how this also clusters with cancer death rates. So you can see again this correlation between areas that have higher poverty levels as well as, in the same areas seeing a higher rate of cancer death. Again, clearly showing a linkage between these. So, I think we've also noted that patients who come from underrepresented racial and ethnic groups tend to have less enrollment into clinical trials. And, I think, again, this is also multifactorial. It's interesting when you ask patients of different races and ethnicities if they would participate in a clinical trial if offered, they almost always say yes. And so part of this is also a burden on the physician that we need to make sure that we are making sure that all patients are presented with clinical trial options. Certainly, patients may come from different educational backgrounds and may also have less comprehension of some of these options. And again, that also comes into play here. Um, I think we don't fully understand all of this, again, because it is so complex and multifactorial. Some of this has to do also with biology, where there are clearly biological differences as well by race. So, hopefully we can do better on this in the future. But I think from a physician standpoint, making sure that we do all that we can to make sure that all our patients, irrespective of race and ethnicity, are presented with all the options for treatment, and that we work on ways to overcome barriers. And some of these barriers are systemic barriers. Some can be personal bias, certainly something that we all can work on ourselves. But on the patient side of things, I think there's been years of mistrust within the medical system for very good reason. And so I think this can play a factor into decision making, where, for example, maybe a patient may not feel comfortable and trust their provider, making them not necessarily, be willing, for example, to go on to a clinical trial due to that mistrust. Um, so I think, again, this is not a one size fits all type of approach. But here, I think the bottom line is that we do need to provide patient-centric care. And so that communication needs to be quite clear with the patient. We need to get to know them as a person so we understand what barriers there may be for that individual person, and see if there are ways that we can help them overcome any barriers to obtaining adequate health care, and that we ourselves present opportunities free of bias so that all patients are presented, again, with the same options, irrespective of race and ethnicity. So, I think, again, all these factors need to come in mind when we are communicating with our patients. And, I think we're all working on ways to make the healthcare system easier to navigate as well. So, in terms of structural barriers, I think this is also complex. It does involve understanding social determinants of health, making sure that patients of all different geographic regions have the same access to healthcare, which isn't easy. Certainly, we know that patients that live a far distance from academic medical centers, for example, may not have access to genetic counseling, may have less access to clinical trials. And again, that poses a potential barrier. There are efforts that are being made to have larger access to patient navigation to help patients navigate the complexity of the healthcare system. And that, I think, makes a tremendous data. There's lots of robust data suggesting that. But again, there are, limits on the number of navigators that are present within institutions. And so not all patients do have access to this, which is unfortunate. So, I think taking a multidisciplinary approach is quite critical. When we see patients, making sure that we can provide them all the resources that are there, including things like social work, resource specialists, patient navigators, and helping them, again, navigate through this system is really important. So as we move forward and thinking about adequate treatment for breast cancer patients, I think it's important to make sure that, again, we are really getting access for all patients to these really important treatment options. So when thinking about unmet needs in metastatic breast cancer, we're fortunate that we do have many highly effective therapies, But I think the challenge is that some of these therapies have limited efficacy and certainly can have impact on quality of life. And so, for example, in hormone receptor positive disease, once patients progress through endocrine therapy, traditionally we had been turning to chemotherapies, which again, do have an impact on overall quality of life. And as you can see, as shown in the table, as patients move through lines of chemotherapy, you can see that the duration and time on subsequent lines of treatment gets shorter as people move on to subsequent treatment. So again, limitations in a patient who's had prior treatment in terms of the efficacy that we are providing. And so one way to go beyond that is to think about utilization of antibody drug conjugates. These are very unique drugs that take an antibody that is looking to bind to a particular target. The goal is that that target is more expressed on a cancer cell than on a normal cell, that you are, again, trying to specifically target the cancer cell and spare healthy normal cells. And these antibodies are linked to chemotherapy. And the idea here is that you can put multiple molecules of chemotherapy on one antibody. And so you're able to deliver very high doses of chemotherapy in a targeted manner right into the cancer cell. As technologies have improved, we've learned how to develop different linker technologies, with the idea being that maybe if you had a cleavable linker, you could allow that payload to be released and diffuse through the cancer cell membrane into a neighboring cancer cell and function via bystander effect. And this can be important, for example, if the neighboring cancer cell lacks the target expression, and then you still can get cell kill despite not having target expression, even with the use of an antibody drug conjugate. So again, we've seen this technology advance over time, and as we've seen that happen, we've also seen efficacy dramatically increase with these newer ADCs. So this schematic really shows the general idea, which is that you have an antibody drug conjugate that's specifically targeting a particular protein that is present on the cell surface. In this case, in this diagram, you see TROP2. This is an ADC targeting TROP2. That ADC gets the whole thing, gets internalized into the cancer cell. There is release of the payload intracellularly that then causes cell death. And then that payload, again, if cell permeable, can then diffuse through the cell membrane into a neighboring cancer cell via bystander effect and kill that neighboring cancer cell. So again, you can see the process by which these drugs work. Certainly the mechanism is not quite as clean as maybe this diagram suggests. There can be, for example, a mild amount of payload release, for example, in the tumor microenvironment. So there can be some free payload that can emerge. And again, that is part of the idea with the construct of these ADCs, is to really try to spare payload release into the bloodstream, so you're getting less off-target toxicities. So this is just a schematic showing an overview of antibody drug conjugates that specifically target TROP2. So the first TROP2 directed ADC to reach approval has been sacituzumab govitecan. This is an ADC targeting TROP2 that has a cleavable linker and has an SN38 payload. So that payload is in fact the active metabolite of irinotecan. So it's a topoisomerase 1 inhibitor. And sacituzumab govitecan has a very high drug to antibody ratio at about 8:1. So again, a very potent ADC. This ADC has been FDA approved for both metastatic hormone receptor positive as well as metastatic triple negative breast cancer. So a great treatment option. We'll review the data that led to those approvals. There's also another TROP2 directed ADC, datopotamab deruxtecan, or Dato-DXd. This ADC also targets TROP2. In this case, it also has a cleavable linker, but the payload is deruxtecan, which is a different topoisomerase 1 payload. The drug to antibody ratio with Dato-DXd is slightly lower than it is with sacituzumab. It's a 4:1 ratio. And we have seen data already presented from TROPION-Breast01 showing the efficacy of this ADC in metastatic hormone receptor positive disease. So we're hoping to see approval for this ADC in the not too distant future. We also have another TROP2 ADC, a newer one, SKB264, also known as MK2870. And it now has the name sacituzumab tirumatican. This ADC is also targeting TROP2, has a cleavable linker, and has a topo-1 payload. In this case, it's a belotecan derivative that is the payload. So lots of really exciting TROP2 ADCs. The first approval for a TROP2 ADC was based on the ASCENT trial. This was a trial specifically for patients with pretreated metastatic triple-negative breast cancer, and the trial targeted patients who were really receiving treatment with a minimum of 2 prior lines of chemotherapy in the metastatic setting. But I would note that if you recurred within 12 months of your adjuvant therapy, it counted as a line of treatment. So in essence, there were patients in the metastatic setting getting treated in the second line and beyond. And patients were randomized to get sacituzumab govitecan or treatment of physician's choice chemotherapy, and the primary endpoint was progression-free survival. And I think what we saw was pretty striking, where the sacituzumab was significantly better than the standard chemo. You can see the PFS with the chemo control arm was only 1.7 months. I think that goes to show how poorly we do with standard chemotherapy in the pretreated triple-negative setting. In essence, this suggests most patients were progressing on their first restaging scan. Whereas when you look at sacituzumab govitecan, you can see the PFS in essence is 3 times as long. It's 5.6 months. So the hazard ratio here was about 0.4. So very dramatic improvement in PFS, but very importantly, also a dramatic improvement in overall survival with, in essence, a doubling of overall survival going from about 6 to 12 months. So given these data, sacituzumab govitecan did get approved for the treatment of metastatic triple-negative breast cancer. And in fact, most of us would use it in a second line or later line setting, given these data. When you specifically look at that subset of patients that were treated in the second line, again, remember these were patients who had to have relapsed within 12 months of adjuvant therapy, then gotten 1 line of treatment for metastatic disease, and then went on to the trial. You can see that the benefits seen in the second line are really very much consistent with the overall population. You see the same 5.7-month PFS for the sacituzumab compared to only 1.5 months for the control arm, and also, again, a doubling of overall survival, clearly establishing this as a standard second-line option. One question that arises, though, is, well, this is an ADC targeting TROP2. So wouldn't you think that the benefit would be better in someone who's a high TROP2 expressor, and maybe think it may not work if someone had very low TROP2 expression? But in fact, what has been seen is that irrespective of TROP2 expression, sacituzumab always did better than the chemo control arm. So you can see here, you can see the PFS by tertiles of TROP2, and you can see that, again, every group has a better PFS. Even the low TROP2 expressors did better with sacituzumab compared to chemotherapy. So at this point, we would say you don't need to test for TROP2 because the sacituzumab is always going to do better. But I will say one thing that's interesting is that as TROP2 expression increases, you do see that the sacituzumab PFS is also increasing. Again, suggesting the more target expression you have, the more robust the efficacy is. And so I think, time is going to tell that if in the future, maybe we have a ton of different ADC options, maybe we will need to think about target expression to figure out what the best ADC would be for that patient at that point in time. But for now, we don't need to use TROP2 expression to figure out who gets sacituzumab, because it's always better than the chemotherapy that we would otherwise be giving. The other question that arises is, what about HER2 expression? Because we do have another ADC, trastuzumab deruxtecan, that is approved in HER2 low triple-negative breast cancer. So you could think, well, how does this TROP2 directed ADC do if someone's HER2 low compared to HER2 zero? Is there a difference in outcome? And in fact, it didn't matter. So irrespective of TROP2 expression, you're seeing benefit for sacituzumab relative to standard chemotherapy. So HER2 expression should not influence the decision to choose sacituzumab. So because this drug was so robust and better than standard chemotherapy, there's obviously an interest to move it to earlier line settings. And so there are ongoing registration trials that are specifically focused on first line metastatic triple negative disease. This is the ASCENT-03 study that is for first-line treatment of PD-L1 negative metastatic triple negative breast cancer, comparing sacituzumab to treatment of physician's choice chemo. In fact, this trial just recently completed accrual, so we are waiting data from this trial, and hopefully it will show us that this could become a new standard of care in the first-line setting. And I think of this as a sister study, which is looking at the PD-L1 positive cohort in the first line setting, looking at sacituzumab pembrolizumab and comparing it to chemo pembro in this population that is what I think of as the Keynote 355 population, the patients where we normally give chemo checkpoint to. It's trying to see if we could do better with sacituzumab pembro. And this study is getting near the end of accrual, so hopefully again, we will learn more from this trial. So again, while we've clearly established sacituzumab govitecan as a standard of care right now in the second line and beyond triple negative setting, and have ongoing studies to look at it in the first line triple negative setting, we also have another ADC for triple negative disease as well as hormone receptor positive disease, and this is T-DXd. It is specifically for patients who do have some level of HER2 expression. These are not patients who have HER2 positive disease, but rather they're what we traditionally had categorized as being HER2 negative. So having, not being IHC 3+ and not being FISH amplified, but having some IHC expression, meaning that there's enough expression there to have a target so that you could deliver the chemotherapy into the cell. And so the concept of using low target expression for ADC delivery was really studied in Destiny Breast 04, where they took patients who had HER2 low breast cancer, so IHC 1+ or 2+ and not FISH amplified, and randomized them to get T-DXd or standard chemo. And this was for patients who had 1 or 2 prior lines of chemo in the metastatic setting. And the primary endpoint was progression-free survival in hormone receptor positive breast cancer. So the trial was really designed for metastatic hormone receptor positive disease, but had a tiny cohort, in fact, just 58 patients with triple negative breast cancer who were treated in the study. But it wasn't powered for that triple negative subgroup. It was powered for the hormone receptor positive group. And what we saw was that T-DXd did better than chemo, significantly better in terms of both progression-free and overall survival, specifically in the hormone receptor positive subset, as well as in the intent to treat population, where you saw the PFS go from about 4 to 9 months. So again, more than a doubling of progression-free survival with T-DXd compared to chemo. And you also saw there was a significant improvement in overall survival, both for the intent to treat population as well as a hormone receptor positive group. Interestingly, when you look at the response rates, you can see that the T-DXd, in my mind, hit a home run with response at a little over 50%. We don't see that level of response with chemotherapy in this setting. And you can see that because the control arm only had a 16% response. But what to me was interesting is that the response rate was really, in essence, the same in the hormone receptor positive and triple negative patients. And we don't usually see that. Usually triple negative disease is often a little bit more chemosensitive and tends to have a little bit higher response rate. But here again, what you're seeing is identical objective response that is extremely robust. So you're seeing the same signal. And so I think that's probably what led the FDA to feel comfortable with approving T-DXd, not just in the hormone receptor positive patients, but also in the triple negative subgroup that has HER2 low expression. And so for now, when we think about triple negative breast cancer, right now, again, I think this is going to keep changing, but right now we make sure we've tested for several biomarkers, PD-L1, BRCA. We make sure that we know their HER2 low status and that we've obtained next generation sequencing to know if there are any targetable alterations, such as having high TMB, MSI high status, or even rarer alterations like NTRK fusion or RET. And so that information, in my mind, is super critical when you're going to make a decision about what to do, because in the first place, you need to know, are they PD-L1 positive? Because if they are, the standard is generally to give chemo with a checkpoint inhibitor, whereas if they're PD-L1 negative, we're usually giving chemotherapy as alone, or if they have a germline BRCA alteration or a germline PALB2 or somatic BRCA alteration, you could offer a PARP inhibitor in that upfront setting. And so I think that fork by PD-L1 status and by BRCA alteration status is really critical for that first treatment decision. But then once you've given your first line therapy, I'm usually thinking about an antibody drug conjugate next for most patients. And in my mind, given the robust data from ASCENT, I would use sacituzumab govitecan in the second line setting. If they were HER2 low, I would traditionally sequence that TDXD post sacituzumab. Again, one could argue you could switch that order around, but I've just traditionally used this sacituzumab because there was a large phase 3 study establishing it to be, associated with PFS and OS benefit, whereas with TDXD, we just had a small subset of 58 patients with triple negative disease, and so not quite level 1 evidence, and so I've typically sequenced it later. But hormone receptor positive disease also has benefit from antibody drug conjugates with specifically these TROP2 ADCs. And so we did have a registration study, TROPiCS-02, that looked at sacituzumab in pretreated metastatic hormone receptor positive breast cancer, but it was for patients who had already progressed on endocrine treatment with a CDK4/6 inhibitor. They had already had prior chemotherapy in the metastatic setting with at least 2 lines of chemo and no more than 4, so pretty heavily pretreated, and then got randomized to sacituzumab or chemo of physician's choice. And the primary endpoint was progression-free survival. And what you're seeing here is a very significant improvement in both PFS and OS. And so I think, again, important to think about sacituzumab for this pretreated population. One thing that does come up is thinking about not just response rates, but also is there an impact on quality of life? And so in terms of response, you see that the sacituzumab was better in terms of objective response rate than standard chemo, with a response rate of 21% with sacituzumab compared to 14% in the control. And then when you look at time to deterioration of global health status, you can see that it is delayed with sacituzumab compared to chemo. And I think this makes sense. This is a more active drug. It's probably controlling patients' symptoms from their disease better. And so again, you're seeing that the time to deterioration in their health status is delayed. It is associated certainly with some fatigue, but again, it was more delayed than chemotherapy was, telling us that this is a tolerable regimen and not having an impact that's outweighing its efficacy benefits. As before, when we talked about sacituzumab, the question always comes up about biomarker predictors of benefit. And here again, you see HER2 status did not impact benefits. So it didn't matter if you're HER2 low or HER2 zero. The efficacy for sacituzumab was the same and always better than standard chemo. And this was true both for PFS as well as for overall survival. And so given, again, the robust data for sacituzumab, this was used in a heavily pretreated patient group, 2 to 4 prior lines of chemo. So the interest is to see, can we move this drug earlier? Could this be a chemo option maybe as their first chemotherapy? So there is a trial that is currently enrolling called ASCENT-07, taking patients who've already progressed on their upfront endocrine therapy and then randomizing them to sacituzumab or treatment of physician's choice chemotherapy. So this could help move sacituzumab into an earlier line treatment option. There's also Destiny Breast 06 that was just recently presented at ASCO that compared TDXD to chemotherapy in patients who had just progressed on endocrine treatment and had not had prior chemotherapy in the metastatic setting, and also showed that TDXD improved progression-free survival compared to chemotherapy. So the chemo had a PFS of 8 months compared to about 13 months with the TDXD. And so I think these data do suggest that TDXD can be an option for HER2 low metastatic hormone receptor positive breast cancer in the first line chemo setting. It did have a small subset of patients that were HER2 ultra low. This is a new category, if you will, for HER2 expression, which means they have expression that's somewhere between 0 and 1 plus staining. So not HER2 null, but also not HER2 1 plus. They had a little bit of faint staining. And in that 150 patient subgroup, you also saw benefit for T-DXd compared to chemo, though not powered for that subset. So I think that will bring up a whole new set of questions for us, which is surrounding, can we use T-DXd in people who are ultra low expressors? And I think the challenge is we don't currently have a great way to test for that. And so I think we're going to have to learn if that's something that we can actually test for to see if we can select those patients. But for now, I think given DB06 data, I think T-DXd does become an option for patients in that first line setting. Though I'll say there may be some patients who you may elect to give something like capecitabine to first, maybe someone who doesn't have a lot of visceral metastases, has been super endocrine sensitive. Maybe you're not ready to jump the gun to T-DXd given, they could have an oral therapy option. So I think lots of factors to weigh in, but clearly really impressive data that came out from Destiny Breast 06. So the guidelines haven't been updated yet with Destiny Breast 06 data. So right now they've positioned T-DXd as a second line chemo, but I do think that will change once guidelines are updated based on Destiny Breast 06. And given data for sacituzumab govitecan and its benefits in TROPiCS-02, it has been positioned as a second line chemo option in the metastatic hormone receptor positive setting. There are other TROP2 ADCs, though, as we talked about. There's Dato-DXd, which again is a TROP2 directed ADC with a deruxtecan payload. It has a drug to antibody ratio of about 4-to-1. And we had seen initial data in a phase 1 setting suggesting robust activity for Dato-DXd in both hormone receptor positive as well as triple negative breast cancer. And the registration trial for Dato-DXd in metastatic hormone receptor positive disease has been presented and did demonstrate that Dato-DXd did do better than standard chemotherapy. And so here you can see the patients that were enrolled in this trial, TROPAN-Breast 01. The eligibility here was very much in line with Destiny Breast 04 in terms of lines of prior therapies. Those 1 or 2 prior lines of chemotherapy in the metastatic setting. And in fact, the majority, about 80%, had seen a prior CDK4/6 inhibitor. And what we saw was an improvement in progression-free survival going from about 5 to 7 months, so about a 2-month improvement in PFS, and that this benefit was really seen across all subgroups of patients. Data for overall survival is still immature. It did have a trend towards overall survival, but we are awaiting final overall survival data. This is the response data, again, suggesting Dato-DXd did better than standard chemo with respect to response, with a response rate of about 36%. And again, as we noted, survival data is still immature. What's really interesting to me, though, is that, it's nice to have another TROP2 ADC, but it's interesting that the toxicity profiles are quite different. With sacituzumab, we're very used to seeing neutropenia and diarrhea. Whereas with Dato-DXd, we actually don't see neutropenia. And the major side effect, in fact, is stomatitis and nausea. So it's really interesting that you see ADCs that both have TROP2 targets and both have topo-1 payloads have very different toxicity profiles. And in fact, what was nice with this particular trial was that the rate of grade 3/4 toxicity was lower with Dato-DXd compared to standard chemotherapy. We don't say that very often for antibody drug conjugates to have less grade 3/4 toxicity, but interesting to see that that was the case with this agent. So given the robust data with this drug, it's being studied in multiple other trials, and the goal has been to move this drug earlier. And so there are trials looking at Dato-DXd in the first-line metastatic triple-negative setting. This is TROPAN-Breast 02, looking at it as first-line treatment for PD-L1 negative metastatic triple-negative breast cancer in the first-line setting, comparing Dato to standard chemo. And so hopefully we will see results in the near future with this study. There's also a sister study that I think of as TROPAN-Breast 05, looking at Dato plus durvalumab in the first-line PD-L1 positive setting. So, I think, again, lots more to come from Dato-DXd. But as we get all these drugs, I think one of the challenges we're going to find and are already finding is, can you give one ADC after the other? When we studied these ADCs in the registration trials, patients were not allowed to have had a prior antibody drug conjugate when they went on to the study. So in fact, we don't really understand efficacy of sequential ADCs. But we do have approvals, for example, for sacituzumab and T-DXd, and we do use them sequentially without really having robust data. And as Dato-DXd emerges and comes onto the market, and other ADCs like sacituzumab tirumotecan, the NK-2870 TROP2 ADC, what are we going to do? Do we sequence them? Will one ADC work after the other? Can you use a TROP2 ADC one after the other? I think, again, so many questions that we don't have the answers to, but there are studies that are planned to try to address this question. And this is one such example called TRADE DXD, taking patients starting with one ADC, in this case, either T-DXd or Dato-DXd, and then going to the other. So if you get T-DXd first and you progress, you then go on to Dato-DXd. If you got Dato-DXd first and progressed, you then go to T-DXd. And it's directly sequenced without any therapy in between, and it has biopsies to help understand mechanisms of response and resistance to sequential ADC use. And the cohorts are separated based on hormone receptor positive status, so you can understand if there may be differences in efficacy within triple negative compared to hormone receptor positive disease. So I think we need data like this to help us really understand how we can utilize ADCs one after the other. And so while these drugs are highly efficacious, they obviously do come with side effects, and it's important to think about them when managing patients on these drugs. And so, as we alluded to, sacituzumab govitecan is associated with a high rate of neutropenia, with about half of patients experiencing grade 3/4 neutropenia, and about half of the patients requiring growth factor utilization. And that's really critical, because you do want to introduce growth factor if patients are developing grade 3/4 neutropenia, so that you keep them on schedule and you prevent infectious complications. The other thing to keep in mind with sacituzumab is a risk of diarrhea. Generally, I've felt like the diarrhea is mostly low-grade intermittent diarrhea. Rates of high-grade diarrhea are under 10% with sacituzumab, so quite unusual. But it is critical that we do let patients know about these side effects. Make sure, for example, they have loperamide on hand when they start this drug, that you do think about other side effects like nausea. Make sure they get adequate prophylaxis for nausea. In this case, I use 2-drug prophylaxis. And the other thing to keep in mind is that the payload you're delivering with sacituzumab is SN38. And so if you had reduced UGT1A1 activity, you could have more toxicity. For example, we see patients with star 2828 having more neutropenia and diarrhea. And so it's not currently recommended to require UGT1A1 testing up front to know if they have the star 2828, but rather if someone's developed significant neutropenia or diarrhea, you could certainly test for it, and that would help you understand that maybe dose modification would be really critical in those patients who are not good metabolizers. So we talked about the fact that neutropenia is very common, and so it is important to think about growth factor utilization. But one question comes up is, well, how do you actually use a growth factor on a drug that's given on day 1 and 8 of a 21-day cycle? And so what I typically do is I'll either use short-acting GCSF on days 2, 3, 4, and a long-acting like pegfilgrastim on day 9, or sometimes I'll just use that day 9 long-acting dose if they're just someone who's usually neutropenic at day 1. Whereas if they're neutropenic on day 8, you usually will need some growth factor after your day 1 dose to make sure their counts are okay at day 8. So I think all these things you have to keep in mind when you're factoring in how to think about the growth factor. Certainly dose modification is also an option to help you deal with the neutropenia and lessen the toxicity from that. And we talked about the GI toxicity, including the diarrhea, usually well managed with loperamide. There is nausea as well with sacituzumab, although, I don't think of it as very highly emetogenic. So I usually have used 2-drug prophylaxis. So something like a Decadron and Zofran becomes very effective in these types of strategies for prophylaxis. One funny thing I think people forget about is that these drugs, the SN38 can cause an early cholinergic response, just like you see with irinotecan, for example. Again, it is the active metabolite of irinotecan. So if someone gets that diarrhea that occurs, during the infusion or just shortly after infusion, that may be a cholinergic response. And so to think about atropine for cholinergic symptoms is really important because it does work. And so if someone has that and the atropine works, then I think about prophylactic them with atropine with subsequent cycles to really prevent that cholinergic symptoms. And then in terms of diarrhea, I think we're all pretty used to managing diarrhea. Obviously, if someone had severe diarrhea, they could even require hospitalization and fluid resuscitation. One can think about octreotide in someone with severe diarrhea to help stop it up. I'll say I've been using sacituzumab for years and haven't had to do that, but certainly it is an option. We talked about the nausea, using 2-drug prophylaxis for that, again, works quite well. The other thing with alopecia is I would say all my patients really go bald with sacituzumab. I've never had someone keep their hair. But we don't really know if scalp cooling works with these ADCs, which do have a slightly longer half-life than traditional chemo. There is a study currently ongoing, actually being run by one of my colleagues here at Dana-Farber to understand the efficacy of scalp cooling and trying to prevent alopecia, but we don't have those data available yet. But I will say certainly people do try it in case it could help. With TDXD, the typical toxicities you have to worry about is one, nausea. This is usually highly emetogenic, and so 3-drug prophylaxis is required. 2 would be interstitial lung disease. This occurs in 10 to 15% of patients, and there have been deaths due to ILD. And so very critical that you are monitoring for ILD very closely and stopping if anyone ever develops symptomatic ILD. Because it is a HER2 targeted drug, you can get cardiac toxicity and subsequent left ventricular dysfunction. And so cardiac monitoring is required with utilizing TDXD, just like if you're utilizing trastuzumab alone. And then alopecia can occur, although I will say going bald from TDXD probably occurs more in 25 or so % of people. Some people get thinning, but I think going really bald is usually about a quarter of patients. And so again, something to warn patients about that it is possible, and that again, we don't know the efficacy of scalp cooling yet at this time. So in terms of the ILD, again, it occurs in 10 to 15% of patients. The majority tends to be grade 1 or 2, but there have been fatalities reported from ILD, usually 1% fatality rate across most of these studies. And so very critical that you are warning patients about this, that they are to call you if they develop any signs of shortness of breath or dyspnea or cough, and that you are usually imaging them more frequently. So usually I'm scanning every 6 to 9 weeks to look for any ground glass changes on imaging so that we could catch that ILD earlier. If someone has a scan and you see some ground glass, but they're not symptomatic, that's grade 1 ILD, meaning asymptomatic ILD with just radiographic changes. For that, you need to hold the TDXD. You can give steroids. I usually give 0.5 mg per kg of steroids and then repeat the imaging in 3 to 4 weeks. If it's resolved, then you can reinitiate TDXD. If it takes longer than 28 days to resolve, then you have to dose modify and dose reduce the TDXD when they restart. But for grade 2 or higher ILD, so anything with a symptom, you have to permanently discontinue the TDXD and never ever give it again, because we don't have safety for re-challenging patients with grade 2 or higher ILD. We do have some safety data for re-challenging with grade 1, so the asymptomatic ILD. We've seen that about a third of patients will get ILD again after re-challenge with grade 1, but not usually, again, very manageable. But we don't have safety with re-challenge for grade 2, so please do not do that, because again, this drug can cause potential fatalities from the ILD. So we talked about the fact that you do need 3-drug prophylaxis with TDXD for nausea, so usually a steroid, a 5-HT3, and typically I use an NK1, so something like a decadron-aloxamine regimen up front. And I usually give patients olanzapine or ondansetron to use for delayed nausea, so nausea that may occur, during week 2 or week 3. And I find that to be highly effective at controlling that delayed nausea that can happen. The other thing to keep in mind is that cardiac toxicity. So make sure you have a baseline ejection fraction, and then to get periodic, ejection fractions, usually every 3 to 6 months is recommended. And so I think to put all this data into context, it's really helpful to think about a case. And so this is a case of a woman, we'll call her JA, who's a 48-year-old patient who had had stage 3 triple negative breast cancer, had gotten neoadjuvant chemotherapy with anthracycline and taxane, followed by mastectomy and axillary dissection. She did have residual disease and got capecitabine and radiation, but unfortunately, a few years later, developed recurrent disease with lung and lymph node metastases. She was PD-L1 positive, and so got carboplatin, gemcitabine, pembrolizumab, but after that did develop progression. And so remember, we did say as a second-line standard in triple negative disease, you can utilize sacituzumab govitecan given data from the ASCENT trial, and so that's what she received. And so, knowing sacituzumab, this patient, we did educate her about risks of neutropenia and diarrhea, and she did okay for the first couple of cycles. But during the cycle 3 infusion, so while she was getting her infusion, she started having cramping and diarrhea, and so was clearly getting some of those cholinergic-like symptoms, and in fact, subsequent days did have worsening diarrhea. So what do you do when someone has diarrhea like this during, for example, the infusion where they're getting cramping and diarrhea? Would you continue the infusion? This is just expected. Would you stop it? Think this is a hypersensitivity reaction? Would you slow the infusion, or would you utilize atropine? And so I think, remember, keep in mind, this was diarrhea and cramping during the infusion. That seems like a cholinergic kind of response. And so I would say that I think something like atropine would be very effective at managing that. So in this case, the patient, for the delayed that diarrhea that was occurring after that, she did use a loperamide and had good control. But then comes in for cycle 5, day 1, and her ANC is 1100. She's otherwise feeling fine. And so what would be your most appropriate next step? Would you continue the sacituzumab as planned, but use growth factor? Would you hold it until that ANC is above 1500? Would you reduce the dose and continue, or would you just give full dose at that time? So I think this is a little bit of a tough question, because most of us for standard chemo use an ANC cutoff of 1,000 to start treatment. But in fact, when sacituzumab was studied, they used a cutoff of 1,500. And so technically, in this case, you're supposed to hold sacituzumab until the ANC is 1,500 and then start. I will be honest, though, I think most of us who've been using sacituzumab for a while don't really do that. Most of us still just use the 1,000 cutoff and treat, but do have a very low threshold to utilize growth factor support in those patients with borderline neutrophil counts. So I think that was a helpful case, because it sort of hits a lot of the common issues that we have with sacituzumab, for example, like neutropenia and diarrhea. But we could turn to another case. So this is a patient who has a history of de novo metastatic disease that was ER positive and HER2 low, so IHC 1+. For first-line therapy, she got an aromatase inhibitor and a CDK4/6 inhibitor, then went on to fulvestrant, everolimus, and then capecitabine. But after being on capecitabine, did develop new liver metastases. And knowing that the data from DESTINY-Breast04 supported utilization of T-DXd in that second line setting, she then went on to get T-DXd as her second chemotherapy. So she starts on it. She gets 3-drug prophylaxis for her nausea, as we recommended. And she goes through a couple cycles, but then develops fatigue, dyspnea, and cough. So this patient's at risk for ILD, so she has those symptoms. You get a high-res CT, you see patchy interstitial infiltrates, and she does have hypoxia. So again, she has symptomatic ILD. So what are you going to do? Are you going to continue the T-DXd? Or are you going to stop it, start oxygen, consult pulmonary, initiate steroids? Or are you going to hold it and do all that stuff, and then think about restarting when she's better? Or are you going to hold it and reduce the dose level once it's resolved? And so I think this is a super important question because for symptomatic ILD, you really don't want to ever retreat that patient. So you do need to permanently discontinue the TDXD and start steroids. In this case, she probably needs to be on oxygen and consult pulmonary. So, I think really, really important when we're thinking about patient and all these decisions is that, this is a shared decision-making process. It's really important to understand the patient's individual needs and figure out what makes sense for them at that particular point, and to really make sure that we are really monitoring for adverse events and trying to avoid any potential complications for these drugs. So, I think again, there's a lot of evolving data in this space. We touched upon even the new data for Destiny Breast 06. So I think a really exciting time. So I'd like to thank you, our audience, for participating in this activity today and really for continuing to work to provide the best care that we can for our patients. And please think about engaging with us during social media. So this is on X, or formerly known as Twitter. So you can look at CE Concepts or CEC Onc, and please do connect. So thank you so much.